So I think we all give you our thanks in advance for your early morning start tomorrow. So we'll move on to the next case now, and Jennifer Thoreau, who is a fellow currently at the Brompton, who's in London all the way from Australia. So welcome, Jennifer.
Thank you.
Please start your case.
Thanks. And can everyone hear me and see the slides okay?
Not the slides, we can hear you, Jennifer, but it's coming up. We have it now. Good.
You have the slides now? Perfect.
We do, yeah. Go ahead, please.
Okay, excellent. So I'm going to present a case that came through us again recently. So his name is Mr. GG. He's a 53-year-old gardener who a few years ago initially presented to Northwick Park A&E urgent care complaining of a productive cough for 3 weeks. History was a little bit difficult to start with as he spoke minimal English. He was over here working from Romania. He reported that he had no medical history, been previously well. He was an active smoker at the time and on no regular medications. The team there soon twigged that something was a little unusual about him. This was his a very initial ECG, so it showed a sinus rhythm, very peaked P waves, had evidence of pre-excitation and a left axis deviation. He also had a chest x-ray initially. This is actually a couple of days after presentation. And you can see that he obviously has an increased cardiothoracic ratio, and there's a little bit of plethora in the lungs and some upper lobe redistribution. And this was the initial transthoracic echo that he underwent. So you can see that this shows both the moderately dilated left ventricle with severely reduced systolic function. There's a lot of spontaneous echo contrast, which is always concerning, and also severely reduced RV systolic function with obviously a displacement of the tricuspid valve and atrialized basal and mid segments. And this was suggestive of an Epstein's anomaly at a surprisingly late diagnosis. Also had was transferred then from the Northwick Park Hospital to the Royal Brompton Hospital and underwent a cardiac MRI and also a CTCA as ongoing workup. And the cardiac MRI, also consistent with Epstein's anomaly, showed a dilated functional right ventricle, severely reduced function, also dilated left ventricle with severely reduced function, estimated to be 21%. If anything, that view that I've showed you representative probably overestimates that. He also had some, importantly, late gadolinium enhancement of the atrialized right side of the ventricular septum, which did extend to the basal inferior left ventricular wall. He also had a CT coronary angiogram because in a smoker with some chest pain and a very minor troponin leak in the context of his presentation, we wanted to exclude any coronary abnormalities. And there was surprisingly only a very small amount of atherosclerotic plaque and no obstructive lesions. He did also undergo a cardiac catheterization during this hospitalization, which showed some precapillary pulmonary hypertension. His mean PA pressure was 30 and his pulmonary wedge pressure was 25, suggestive left-sided filling pressures. His more acute issues during that presentation were of tachyarrhythmias. We noticed on his very initial ECG that he had that picture of pre-excitation, and he had captured nicely on a 12-lead recurrent orthodromic AVRT, and we involved our electrophysiology colleagues in that one, of course. There is a nice, someone had thought to hook up the 12-lead ECG when he had some adenosine, and this shows a nice resolution of the AVRT back to his sinus rhythm with the delta waves of pre-excitation still shown. So he underwent an EP study and ablation of accessory pathway. That night, he then had recurrence of his AVRT and had a repeat EP study during that hospitalization just a couple of days later, where another 2 accessory pathways were found and successfully ablated. So from that presentation, he was commenced on heart failure therapy. He started bisoprolol, enalapril, some eplerenone, and he also had a small dose of aspirin. And when we next caught up with him in clinic 5 months later, he was feeling very well. He was back at work. On cardiac MRI, his LVEF had recovered to 51% and RVEF to 47%. He did a good exercise test with a peak VO2 of 33.3. And you can see nicely that his BNP at presentation to our hospital at 380 had trended down and stayed in double digits, about 50, I think, is the last result on the end there. However, as we would unfortunately somewhat commonly see, we were not able to keep hold of him forever. And 1 month later, when our next clinic was to follow up on all of the cardiac MRI and the exercise test results, he didn't attend to that clinic, and then 2 subsequent EP clinics, and was lost to follow up from there. And the next that we had from this chat was 6 years later, at the beginning of this year, when he presented to his local hospital with some palpitations. He'd been working in construction up until that point and still smoking and feeling generally well. And he presented with this broad complex tachycardia. He had some hypertension associated with this, and he was promptly cardioverted. He had a slightly stormy course after this. He had, after the cardioversion, severe biventricular dysfunction, persisting hypotension, and a shocked state. There was also some concern for some aspiration pneumonia, and he ended up intubated, ventilated on multiple inotropes in our ICU. And his problems didn't quite end there. He had a slow wean from the inotropes and was progressing well from that point of view, and then altered neurology was noted on his sedation wean. A CT head initially showed some small old infarcts, and then 1 week later, when that hadn't improved, a repeat CT head showed a malignant right MCA. At the time, he had another repeat echocardiogram that didn't show any LV thrombus, which was the concern with his severe LV dysfunction. However, a bubble study was positive for PFO, which is important to keep in mind and is commonly associated with Epstein's anomaly. He was under the stroke physicians, and once it was safe in terms of the large burden of infarct, he was commenced on clopidogrel from that. And he had a slow recovery in his local hospital. He, however, was quite lucky. He did recover well, and after a few weeks had persisting left hemiparesis and was discharged to a smaller DGH to continue with a neuro rehab plan. And in discussion with us and a multidisciplinary meeting at the time, once he'd finished his neuro rehabilitation, the plan was for him to follow up with our electrophysiologists and also the ACHD team and manage him from there. He did manage to quit smoking during this admission, pleasingly. So after his discharge from the neuro rehab, and he was back at home living with support from family, mobilizing independently with a single point stick, he had an electrophysiology telephone clinic. He did complain of some ongoing palpitations and some minor shortness of breath on exertion. Our plan was to bring him in and see what was happening. This was, for context, sort of peak pandemic times where everything takes just that little bit longer than you want it to. And so 1 month later, he presented to a different hospital. Each of those presentations were to different hospitals, to his local A&E, with palpitations again. He was conscious with this rhythm and not particularly hemodynamically unstable. He did have adenosine initially, which is bold, and this did not have any effect. And then he was cardioverted to sinus rhythm. He was admitted under the cardiology team there, had a exceedingly mild troponin rise to 31. BNP was 589. And he was continued on, at that stage, he was already on some amiodarone from his previous broad complex tachycardia. He was continued on bisoprolol, clopidogrel, and obviously they gave us a call and said, we've got this man who's hasn't physically been to see you, but we've been trying to catch up with him for many years. What would you like us to do? And this is where I would just like to involve the panel or the audience at this stage and say, as the registrar who's receiving the outside calls on that day, who do you go to first? Do you go to your electrophysiology colleagues, your interventional colleagues? Do you talk to the surgeons? And what would be your sort of first step from there?
Okay, thanks, Jennifer. I was just looking. I don't think we've got a poll set up there for the audience. Professor Wald?
From our standpoint, unfortunately, due to lack of compliance, smoking, he's not, although he quit, a transplant candidate at this time. So it's up to the electrophysiologists or the surgeons to do something.
Michael?
Maybe I'll let Andreas comment first, but if you want to be devil's advocate here, the patient is 57 now.
60 now.
60. The patient survived to 60 without an operation with severe abstinence. And if the patient was picked up, diagnosed early in parts of the world, he would have had intention to treat tricuspid valve surgery. And if he was alive 40, 50 years on, would be claiming great success. And I think Joyce mentioned, and yourself, Jenny, of the additional risk factors that obviously this chap is in his own world. So just being the devil's advocate, and he's now 60, survive with this. So off to Andreas. Sorry for intercepting, but just to spice it up a little bit.
Thank you, Michael. Sorry, I had some proper electronic issues earlier. I missed Jenny's first part of the presentation, but I assume this is an elderly Epstein patient with decent left ventricular function. I don't know what the LV is like, but let's say this is, for the sake of argument, having missed the beginning, this is a patient with severe TR who is functionally in reasonable nick, but has got signs of progressive RV impairment or has signs of CPET impairment, which is progressive, then I would be inclined to offer surgery to enhance or to decrease the volume loading to the right heart and to improve cardiac index, which is clearly something that the operation generates. If it changes if you like, the long-term outlook of the right ventricular disease, is I think very difficult to prove in this age group. I think it does when you are in a younger age group, hence the fact that people tend to be a little bit more aggressive nowadays with being able to reproduce the results that Giuseppe da Silva and Joe Delaney have been demonstrating. I think that there's more and more patients coming through the woodwork, but I fully appreciate the reticence amongst many of the congenital cardiologists around the world in still not wanting necessarily to have every Epstein patient operated on. But in summary, I think if the patient is kind of in their 5th, 6th decade of life, I think you need to kind of look more at the kind of the magnitude of the exercise impairment, because most of the time it really is a function of their RV volume loading, if they will really benefit or not. And if they haven't got any arrhythmias, then I think it is much less likely that they end up having an operation than if they do end up with arrhythmias. I think arrhythmias is just a sign of the sickness of the ventricle.
So a couple of questions, Jennifer, at this point I'd want to know is, I'm not sure if he's had his coronary imaging updated, given that he's sort of been off the radar for at least 6 years. And also, what did your EP colleagues say in the first instance?
So I might continue on and show you some more pictures. So those are exactly the thoughts that we had, particularly when he presented back at the start of this year with a broad complex tachycardia and severe LV dysfunction. We in fact asked for him to have an angiogram when he was discussed with us, but he was so unstable, and then followed by a large sort of malignant CVA, that was deferred, and so he had not yet had coronary imaging. So he did have that at the hospital he was in with the current event, and pleasingly there was obviously some plaque, but there was no obstructive lesions. So we had answered that question, and we also contacted the electrophysiologists who had spoken to him only a few weeks prior. In the meantime, we increased his amiodarone for a short duration, and we arranged admission to the Royal Brompton with some repeat imaging, partly to update his biventricular function and also to plan for EP study and possible ablation. So his, unlike at the start of this year, he had shown some improvement. So his he had a mildly reduced ejection fraction, 42% left ventricular ejection fraction. He did have severe TR on this transthoracic echo, but his RV function was not as poor as it had been at the start of the year. He had a cardiac MRI, partly for mapping purposes, but it did show us that he had a mildly reduced LV ejection fraction of 55%, confirming that it had improved. And his right ventricular, so functional right ventricular ejection fraction on that study was actually 53%. So it seems that he has his biventricular function definitely swings, and probably his arrhythmias have a lot to do with the decompensation of that when it happens. He had some EP mapping done using the MRI data, which nicely shows that the pink area corresponds to the atrialized right ventricle. So you get sort of a feel for how much of the chamber is taken up with that. And as part of that, he also has the late gadolinium again was taken, and we could see that there was septal enhancement, and this appropriately was suggested might be focus for his VT. When he had his EP study and VT ablation performed, they found that they were able to induce a VT that was probably his index presentation at the septal aspect of the base of the right ventricle. There was also a second slower VT, and both of these were successfully ablated, and after subsequent RV stimulation protocols, they were unable to induce any further VT. And so from that admission, he was discharged home. He's still on his medical therapy and progressing well with that. And I think the main features of this is obviously that we've highlighted it's a late presentation of congenital heart disease and complicated with arrhythmia and heart failure, although he's responded very well to mostly arrhythmic and medical treatments. But he does have some important sort of, prognostic indicators that we need to think about, and future decisions sort of to come later this year and with his ongoing care with us will be questions that I would like to sort of pose to the audience that frequently come up, such as implantable cardiac devices. If he's at risk of having this VT events again, although he didn't have a cardiac arrest, some of them were in the past hemodynamically unstable. Stroke prevention as well in someone that has had a proven PFO. And again, we already covered sort of his surgical indications. I think it's with his preserved RV function, he's sort of stable from that point of view at the moment. And I guess the question that we never really know how to answer is how to ensure that we don't lose these patients again and keep them coming back to follow up with us. Thank you.
Great presentation, Jennifer. I think personally I would exhaust all non-surgical arrhythmia targeting maneuvers. And the patient obviously now is anticoagulated to anti-failure therapy, responding well to it, antiarrhythmic therapy. Before I consider high-risk surgical intervention, I'm not denying him an operation. It's as Andrea said, if you have 15 or 20%, you need something, You have it. This chap is 60 now. And what is his neurology, Jennifer? Has he made complete recovery from it? Or?
Unfortunately, not a complete recovery. So he still has a persisting left hemiparesis. So power would be 2 to 3 on 5 on his left side, but he's able to mobilize independently with a walking stick.
And how can we be certain that what we see, the fast tachycardia, is not atrial with aberration as opposed to VT? You know, how can you, I'm not sure whether Ben is on the call to join the panel and tell us, but not to the VT, but, you know, I'm just asking the question, being the devil's advocate again.
Yeah, I mean, there's initially what you can tell from the ECG, which is when the patient first arrives in A&E, and sometimes, especially if someone's known to have an accessory pathway and whether they get antidromic AVRTs, it can be difficult. I think you always assume, particularly if they're in any way uncertain, that it's a VT until proven otherwise.
Yeah.
And otherwise, I think it's really the certainty comes from the invasive EP study and the mapping of an identical looking tachycardia from a high risk area of fibrosis on his cardiac MRI. I guess we can never be 100% certain, but I would say that was fairly reassuring.
Yeah. Did they find it? Was the positive VT stimulus? I thought you said it was negative. Sorry.
A negative after ablation. Sorry. So they in terms of it was a successful ablation, they could no longer induce any VT.
So the patient had an effective intervention.
Yes.
It's got intervention. Sorry, I missed that. So I think we've done a lot of good things for this patient who is 60, and somehow I don't speak Romanian, but communication with him is key for other risk factors and so on. You don't want to end up having this patient dying in intensive care through a high-risk operation unless you must do it. And he's not a transplant right now. He's made it to 60 with severe abstinence. I think, you know, coming back to my initial comment, this is a good outcome of non-intervention, albeit he's not going to have 100 years of lifespan. I hope it's not a very aggressive comment that I'm making, Andreas. I probably would like to close the discussion.
Thank you, Michael. The only thing that I would like to add to the discussion, could you maybe just go back to the cross-sectional images that you had a little bit earlier of the base of the right ventricle? Yeah, if you run those again. I think the important thing to realize with the cone repair is that you fix the base or a substantial amount of the base of the right ventricle, and therefore impair radial function quite substantially. In a patient where you analyze the right ventricle being predominantly dependent on the radial function, like you can see here, where it's almost like an outpouching of the basal function of the right ventricle, which is very, very dynamic. If you almost take that away and are then entirely dependent on longitudinal function of this RV, then you are going to be substantially impairing this right ventricle. So you've got to make a learned judgment on how much ventricular function you're left with after an operation, because I think ultimately it's not about getting a perfect result. It's about achieving ultimate long-term benefit for the patient. Because yes, I'm sure I would be able to achieve a lovely surgical result, but is the patient any better off with that? Or is maybe the patient worse off with that? Because the RV might not cope very well, and the RV might fail a lot quicker than if you would optimize this with non-surgical options. So I think there's a lot of nuances in the surgical decision making that you need to take into account, and not every Epstein patient is necessarily equivalent to an operation.
I think we'll do what Natalie was asking. We'll revisit the coronaries, and maybe when he recovers from his neurology, it will be helpful also to have his LVEDP or wedge pressure, if he stays under follow-up, and then may come back and discuss him. It's a great case. Yeah, thank you, Jennifer.
No problem.
Okay, I guess one question I would have left over, which we won't go into now, but people can maybe think about and add to the chat, was whether who would consider this patient for an ICD or not, given his recurrent VT and the risk. We assume there is still some risk there, even if the EP colleagues have managed to ablate 2 pathways. But, right, we shall move on.